Good morning and a very warm welcome to our international audience to another educational session. Dear audience, today our topic of discussion is about oculomics. Since centuries, human eye has been considered as the window of human body. Anything happening in the human body is reflected in one way or another in human eyes. And today we are going to discuss about a branch of ophthalmology that is oculomics, using images, analysis of human eye, and then monitoring and evaluating different systemic diseases. In order to discuss this topic, we have got a clinical scientist, Dr. Sahil Thakur, for Singapore Eye Research Institute. Dr. Sahil Thakur is a clinical scientist who has specialized in transformational medicine. He has got almost 100 international publications to his credit. He has done PhD from National University of Singapore on this specific field. He is a supervisor, a mentor, and training students in research methodology. He is also a member of International Association of Prevention of Blindness, Manila Statement. He is also editor of BMC Ophthalmology and an outreach lead Singapore National Eye Center Global Ophthalmology Program. He has written 2 books, he has authored them, and apart from this, he has also contributed to 13 additional books related to ophthalmology. We are very fortunate that Dr. Sahil Thakur, adjunct clinical and research fellow from Singapore Eye Research Institute, has accepted our invitation to educate our audience about this field. So without further delay, I will request him to please present his talk. Yes, please.
Thank you so much, Dr. Mirza, for inviting me. And it's an honor to be here to discuss about this new field in ophthalmology. So a short introduction to me. Thank you. You have already introduced, but my primary affiliation right now is with Medivale, and I am adjunct fellow at 2 places, which is the Singapore National Eye Center, Singapore Eye Research Institute, and also the Duke NUS Medical School. So going on, we'll be discussing oculomics today and how it is being used for the cardio-kidney metabolic disease continuum. We will discuss development of a real-world retinal biomarker. How was it developed? What was the evidence? Where is the evidence? What does it mean for practice for ophthalmologists, for internal medicine physicians, and for anyone who is doing preventive care? I
Excuse
will
me, Dr.
also
Sahil,
go.
a bit louder, please.
Yeah, I will also go through what other biomarkers are available or being developed right now. And in the end, I will share some resources about how the students or anyone who is working in ophthalmology and has access to retinal images can get involved in this field. So when we look at oculomics, it has taken a lot of research. We have taken it from academia to industry now, and I would be first just being very thankful to my mentors who have helped me kind of venture into this field, especially Prof. Jing Yu Cheng and Dr. Tyler Rim. There is a significant amount of academic partnership here. A lot of the data also comes in from the Yonsei University in Korea, and then from our other global collaborators and partners as well. So historically, as you mentioned, even in the early 1800s, people were observing the eye and were in kind of finding out that there is a relationship between the systemic diseases and the eye. One of the first persons to observe this was Van Graaff when he looked at the eye and discovered papilledema, the sign that the optic nerves get inflamed when there is a brain tumor. In addition to that, Marcus Gunn gave us the gun sign, which we can see here, which is the bending of the vessels that you see in hypertensive retinopathy. So we know that especially diabetes and hypertensive retinopathy have very, very specific signs in the eye, and we use these signs to grade these diseases. The unique thing about these signs is when you have these signs, say, for example, the cotton wool spot, the arteriolar narrowing, the AV nicking, these signs are associated with systemic diseases, with clinical stroke, with coronary heart disease, with heart failure, and cardiovascular mortality. However, there is an issue. Ophthalmologists sometimes they don't tend to agree with each other. So the kappa, when we look at people who are grading these signs amongst each other, is very low, especially for the focal arterial narrowing and the arteriovenous leaking, which means that these signs, because they are subjective, they are very difficult to use for clinical purposes. There was a very interesting Google study which compared that even the intragrader reliability, which means when the same image is shown to the same person, is only about 65%, which means that these signs, because they are so subtle, are not immediately usable in the clinical workflows. So, what can be done? So AI comes in to this place. So AI is all around us in our phones, in our cars, in the TVs that we watch today. One of the most common use of AI is the Netflix algorithm and how it predicts what next show that you should watch. And one of the main reasons why this has become so popular is because the GPUs have become quite cheap, and GPUs are the main hardware which are used for AI applications. So there is a specific domain of AI. It is called as deep learning, which is the one that is used for image analysis. Deep learning is very similar to how you teach a small child to read. So you start off from letters, the letters they turn into words, the words they go into sentences, and sentences when joined together can form paragraphs and then write a whole document. Similarly, the images, they are also made up of small pixels. These pixels, when they come together in different configurations, form textures, contrasts, and edges. These can be learned by the algorithm once you give them enough data to learn. And once they learn, they can do unique predictions. They can do unique predictions, like in this case, they can predict whether the diabetic retinopathy is there. It not just that, it can also tell us whether it is severe, whether it is proliferative, or in this case, severe non-proliferative DR. So for Oculomics, there are some building blocks. These initial publications were from Google and from one is from our center. So what they demonstrated was the retinal images can be used to predict systemic biomarkers. Systemic biomarkers, especially that are associated with cardiovascular risk. So smoking status, age, gender, systolic blood pressure, major adverse cardiovascular events. And in addition to that, other biomarkers like the thyroid function, the kidney function, inflammation, diabetes, all of these can be predicted from the eye. So because these things can be predicted from the eye, this field was actually given a terminology that is oculomics, and it became as the study of association between ophthalmic biomarkers and systemic health. So this term comes from the Moorfield group, Proteus Green and Siegfried Wagner's group. The retina is unique. Why? Because it is the only human tissue which allows the direct, non-invasive visualization of the CNS and also the microvascular circulation. So it means not just the heart, but you can also look at the brain tissue at the same time. So systemic changes, it's important to note that they are not just limited to the retina. All different parts of the eye actually show signs of systemic disease. That means we also wrote a publication showing that the front of the eye can also predict anemia. So this is something which is taught in a clinical school as well, that you can look at the conjunctiva and look at anemia. And you also look at the signs of jaundice at the sclera. So again, we are trying to link all the conventional wisdom that was taught with the newer methods that are AI and then adopting it for clinical use. So in the last few years, a lot of interest has come into this domain. In 2022 and 2023, there were a lot of publications. The good part is I did a quick search yesterday, and Oculomics has 70 results now, which means that this field is rapidly growing. And this is the right time to get into this field if you are thinking of building a career in AI and AI's application using the retina or the images from the eye for diseases that are all across the body. So we can understand that the eyes offer a solution. They offer a solution for a lot of systemic diseases. One disease which is especially grown a lot in the last few years is because there is a new umbrella term. So diabetes, kidney disease, all diseases associated with increased BMI, which is obesity-related diseases, have been brought under this one term called as the cardiovascular kidney metabolic health. The AHA, which is the American Heart Association, they gave a presidential advisory and they talked about how we need to focus on prevention. We can say that these diseases together have a significant impact. They are the number one cause of deaths in most of the countries across the world. And approximately 90% of US adults actually meet at least one criteria for stage one of the disease, which means all of us have at least some sign of some presentation of one of these disease conditions, which shows that there is a significant impact as we grow older on the healthcare systems. And if prevention is done, or if ways to detect these diseases earlier can be brought into clinical medicine, there can be significant cost savings. So this is how we went on and developed the retinal biomarker. So this is the publication that describes the idea. As we have discussed previously, the concept is very simple. So you look at the retinal blood vessels, you analyze it using AI, and you try to predict cardiovascular disease. How can you do it? So in order to do it, you need a lot of data. So in this case, we had a lot of data coming in from Korea. So there were about 45,000 image pairs. So these are image pairs which have retinal images, and they have something called as coronary artery calcium. So coronary artery calcium is the calcium that is deposited in the coronary vessels. It is one of the main signs of atherosclerosis, which is the narrowing of the vessels, and you obtain it using a CT scan, which means that it is a modality that has radiation risk, even though that radiation risk is small. But you can imagine if it is compounded across populations, the impact is significant. So once you have these retinal images and these paired coronary artery calcium scans, you can actually train an algorithm to identify signs of CSC in the heart from the retinal vessels. And that is what is the RETI-CSC score. It is actually a score which is coming from the retinal image, which gives a prediction of how much calcium is there in the heart. Once you are able to do this, you are able to stratify people into low, moderate, and high risk. So the images on the right show the performance when the retinal biomarker is compared to the coronary artery calcium. So the retinal biomarker essentially is able to stratify patients into the low, moderate, and high risk. For people who are not very well versed with the prognostication models, what we are seeing here, the graphs are Kaplan-Meier curves. So in Kaplan-Meier curves, what we can do is we can look at people, follow them up over time, and then we can see which of the people are dying, which are surviving. So these survival curves essentially are showing us how the people can be separated on the basis of the score. So the score actually gives a value of low, moderate, and high risk. This one corresponds to the coronary artery calcium scans scores of 0 to 100, and greater than 100. The unique thing about this is we know that there are other non-invasive modalities as well. So there is something called as carotid ultrasound. There is also the branchial pulse wave velocity, which is the measuring of the blood pressure across the major limbs. So we compared all of these against each other to see which is the best performing modality. And what we were able to show again are the same Kaplan-Meier curves to show that the retinal biomarker, when compared with the coronary artery calcium, shows very similar risk stratification. All this analysis is being done in the CMERC high cohort, which is a cohort from Korea. It is a cohort made up of people who have some of the high risk features for cardiovascular disease. The unique part about this cohort was in this cohort, all these tests were done. So the original purpose of the cohort was not developing this model. So again, we are repurposing data that was available to validate a model in this case. So when we looked at the performance, the retina actually performed the best. So herein we see something called as the C statistic. It is one of the ways of measuring performance of a prognostic model. It is very similar to what we know of AUC, which is something that you use when you have a binary outcome, yes or no. In this case, because we have three outcomes, low, moderate, and high risk, so we need a different statistical measure. So the measure here is called C statistic. And the performance here, you can see the retina had the best performance out of the four modalities. Going on, based on this, we can see when we look at the retinal biomarker, it is a very simple scan. It is quite safe, it is quite accurate, highly accessible, relatively affordable as compared to the coronary artery calcium, which we know requires a CT scan, and the carotid ultrasound, which requires an ultrasound operator, a skilled ultrasound operator, and also is not so good at giving cardiovascular risk, even though it is slightly better at giving the risk of a stroke, because again, you are directly visualizing the vessels that are feeding supply into the brain. So, based upon this publication, we managed to get regulatory approval in different countries. There was a very nice paper written which shows all the models which are available right now, which have regulatory approvals. So you can see actually right now only four models are there. So out of the 36 approved models in AI for ophthalmological use, most of them are for DR screening actually. Some of them are for OCT segmentation. Some of them are multimodal models. But there are only four models which can do cardiovascular risk stratification. So we know it is regulatory approved, but is it cost effective? So that's a very important component because a lot of things are regulatory approved but may not be the most cost effective. Say, for example, femtolaser surgery. Yes, the cost is very expensive. It is a very safe procedure, FDA approved again, regulatory approved, but may not be useful when you are going into a camp, say in Africa. So the important thing is to demonstrate whether something is cost effective or not. So there was some work done at ARVO this year. So we managed to show that when combined with the DR screening, which has become a very important component of most public healthcare systems, when you add on the cardiovascular screening, it becomes quite cost effective. So now that we know it is cost effective, how can we implement it in the real world? So you have target patients based upon their initial examination by the physician. They are recommended to undergo a eye scan. It basically goes into the cloud. The cloud analyzes and gives you a report. Based upon the report, the low, moderate, or high risk, the interventions are suggested. So this is a demonstration of how it works. So it works using retinal cameras. The modern retinal cameras do not require the eyes to be dilated. So you can see here the pupil is constricting, which means that even with the undilated retinal images, the algorithms work quite well. Then basically after the image is taken, you upload it into the cloud and you are able to get a report. So the report is essentially the one which is then used for further management of the patients. So this is an example of how it is being implemented into a screening center. So for low risk, nothing is done. They are suggested lifestyle modification. For moderate and high risk, depending upon how many risk factors are there, they can be referred to a cardiologist for further upstream testing. If the risk stratification is not clear after further upstream testing, then CTCA, which is the coronary angiogram, is suggested. So this is an example. We did another webinar some time ago. If someone is interested in seeing how it is implemented in the real world, so they can scan this and go to this. So it is not just enough to validate models using longitudinal outcomes. Why? Because when you go to a physician, you want to show an example. They will ask, can I validate it today? So the good part is there is something called as ASCVD risk calculators. ASCVD is atherosclerotic cardiovascular disease. There are some risk calculators known as the pooled cohort equation, the Q-risk score, and the Farmingham risk calculator. So these risk calculator use demographic parameters like age, gender, smoking, lipid levels, blood pressure. And then on the basis of this, you can give a risk to the person right there and then. But again, you can understand that you need all these parameters, which means it is an invasive test. You need the lipid levels. Only then you can give the risk factor. So we did a comparison with these calculators and we showed that the retinal prediction, which again, important thing is it is non-invasive. You are just taking a photo of the eye and you are predicting risk, gives the predictions which are very similar to these calculators. Again, this is a cross-sectional level evaluation. Always we recommend that because it is a future predicting model, you should always try to get longitudinal data. But if longitudinal data is not there, cross-sectional validation can also be done. So this is also an example of how you can creatively use whatever data you have to structure the problem in a way that you can answer a clinically relevant question. And this is some of the skills that you learn when you do a formal research training program. Going on, it is also important that these AI models, you demonstrate that they work in different populations. So as I previously mentioned, the model was trained using Korean data. We managed to show that the Korean trained algorithm works in UK Biobank, which is Caucasian population, and also it works in the Singaporean population, which is Singaporean, Indian, Chinese, and Malay patients. So when you look at the retinas of these people across different countries, the retina actually has different pigmentation levels. But retinal pigmentation is just one factor. The models are using a lot of signs for the prediction, which means they are using if there is hemorrhage, if there is a vessel thinning, if there is a multiple vessel bleeding, if there is AV nicking. So it is not just limited to the pigmentation. That is why the models are able to perform in a generalizable way across different populations. So in this paper, we managed to show that it works in the Korean, Spanish, and also the Indian population. Going on, once you know it works, how can you link it with a clinical utility? So in this publication, what we managed to show was within the UK Biobank, we made two groups by doing something called as the propensity score matching. So propensity score matching is an artificial way in which you can balance two groups. So in this case, we were trying to see if there is any additional benefit of getting statins into people who have high risk. And what we were able to show in this case was that there is actually a 36% relative risk reduction, 2.68% absolute risk reduction, and a number needed to treat of 37, which means that for every one event prevented, you treat 37 people who have high risk. And this is actually quite a good number to treat. We also took this further. There is something called as metabolomics. So metabolomics basically uses the study of different metabolites in the blood and then associates it with different diseases. So there's a lot of work done in this field as well in systemic disease prediction. So we wanted to see if this metabolite information can help improve the performance of the retinal biomarkers as well. And the comparator in this group was the pool cohort equation, which is one of the risk calculators that I previously described. So what we managed to show in this presentation from the American Diabetes Association was the retinal biomarker itself has a very good performance, which matches the risk calculator. But when you add on information, there will always be some incremental improvement. So there is some incremental improvement in the performance when you add the metabolomic data. The important thing to see here is, yes, there is an incremental improvement. The improvement is very, very small, which means for population-based screening use, actually, the retina may be just enough to search and to look for patients who have high risk. But again, in the research setting where all the parameters are available, or in a tertiary care hospital where all the information is available, when you add on this information, the risk refinement becomes even better. So going on, we also demonstrated some real world evidence. So this one is from a Middle Eastern population from Dubai. Again, we were able to show that this algorithm also works in the Middle East population. So the unique thing is, in a few years, so this is one of my favorite slides to show because it shows how research can impact the real world implementation. So in a few years, what happened was this was an article published in 2021, which talked about what are the in silico methods which are available for cardiovascular risk stratification. And this paper was published last year, which showed that state of the art, one of the method is the eye prediction of the cardiovascular risk, which shows that within about 2 to 3 years, because of the work that was done, the models went from simply being in silico to state of the art. So this has also been reflected in some of the publications which have come out in the high impact ophthalmology journal. So Progress in retinal and eye research as one of the highest impact factor journals in ophthalmology. And Oculomics was recently featured there as a review article, which means there is enough research now for anyone who wants to get started in this field. And it basically also talked about how these models can be cost effective, which I previously also showed, and how they can help in population level health screening. So in addition to the cardiovascular risk screening model, we have also developed the chronic kidney disease model. So this one was developed using the UK Biobank and the Korean diabetic cohort. So again, the concept is similar. You use a lot of retinal images. You use these retinal images which have paired label data, which means the labeling is coming from UK Biobank and the Korean data, whether these people have a CKD, the chronic kidney disease or not. And then you are testing this out in the same data sets to see if the performance is good enough or not. And in this case, also, we are able to show that you can risk stratify people into four different cohorts: the low, moderate to severe, and then very severe. And then what we were able to show was that people who have very high risk, they have significantly higher chances of developing the CKD. So the hazard ratios in this case was 3.68 and 9.36, which are 368 times and 936 times as compared to the lower risk group. So this model, in addition to this model, we were also able to show the unique characteristic of people who are diabetics and they are having hypertensive medications. So we compared those people who have diabetes and hypertensive medications versus diabetes and those without hypertensive medications. Again, we use the same method as the propensity score matching to match these two groups. The data set used was UK Biobank, and we were able to show that people who are on these hypertensive medications actually have higher risk of chronic kidney disease, and sometimes they may require further risk refinement by addition of additional medications. These days, some newer drugs have become available, which can give these people additional benefit, especially the SGLT2 inhibitors. So again, what we are trying to do is first develop a model and then clinically link that model with a clinical question so that they can be adopted into the real world. So in addition to the two models that I described, one for the cardiovascular risk monitoring and then the other one for the chronic kidney disease, there are also a lot of other models which are being developed, especially for the brain diseases, which is Alzheimer's disease especially, and then cognitive decline and incident dementia. In addition to that, we also demonstrated that chronic obstructive pulmonary disease, which is a lung disease found especially in smokers, there also the retina can predict the risk. Uh, as we understand, all the models that I have described up till now, they only do one task. So, for example, the model, if it is trained for cardiovascular risk prediction, it only does that. But there is something called as a foundation model. This is like the Swiss Army knife. It can do a lot of things. So one of the foundation models was developed from the Moorfields group. This single model can do ocular disease diagnosis. It can also do disease prognosis. And as highlighted in red here, it can also do oculomics. So it can also predict the heart disease risk, the risk of stroke, myocardial infarction, heart failure, and also the Parkinson's disease. However, you can understand that if a model is being able to do so many things, it will require a lot of computational power. So in this case, the RET found has been trained using a lot of retinal images and a lot of clinical data, and it is not possible for everyone to say download the model or run it. So what has been done to address this? So the good part is because hardware improves every year, and this is one of the main reasons why Oculomics is growing so much. There is a lot of talk around sustainability in AI development. So this year at Arvo, again, this abstract was shared and the publication also has now come out. Anyone interested can go ahead and read this. So they developed something called as the red found green. So this is a very unique model. Why? Because it was trained using a fraction of the images. All the images are open source, which means they are from the publicly available data. You don't need private data for it. Anyone with a little amount of training, some help from ChatGPT, and a little bit help from YouTube videos about learning a model can actually read this publication and then develop their own model at their home. The good part is the computational cost requirement is now less than $100. It's about 100 times lower than what Redfound was developed with. And it is significantly cheaper to download because it is 14 times faster. The computer embeddings inside it are 2.7 times faster and requires about 2 times less space to store. So overall, it's about 400 times less compute than the original model. So this is how we envision the future of medicine to be. So as I showed you, the compute powers have come down quite a lot. So in the future, there will be these small booths in your malls, wherein someone can sit down, quickly get their eye photo done, get their blood pressures done, and immediately talk to a physician and get their prescription. In addition to that, there are camera attachments for the phones. There are stethoscopes with ECG readings, and there are small ultrasound scanners available today that you can attach to your phone, which means modern medicine will be all on the go. You will not require large bulky equipment for even the most complicated diagnosis. So there are a lot of resources, free resources that are available. Some of the resources are shown here. The best one out of it is the Stanford free course that you can do to learn about how deep learning for computer vision works. In addition to that, there are other courses offered by universities as well. A lot of them can be actually very, very helpful if you are starting out in this field. So finally, why are we here today and why we are discussing it? As I showed you, AI is changing medicine rapidly. There is a large opportunity to capitalize and drive positive change together. And the image on the right shows how the current approach will change and how the newer approach will come in, where most of the diagnosis, most of the prescriptions, and most of the prognosis or management over time will actually become remote in the coming future. If anyone is interested, they can reach out to me. The link is here, and I would be happy to help and collaborate. Thank you again, Dr. Mirza, for having me.
Well, thank you very much, Dr. Sahil. It was very interesting talk. Just a few things I want to ask you. Well, this is all dependent upon artificial intelligence. So, what are the major challenges related to patient data, privacy, and algorithms, transparency, and compliance? Because in multi-country implementation, so what are the challenges you are feeling about this?
Yeah, I think the most important challenge was the lack of open source data. But as I showed in the in the ending of the presentation, that there is something called as red found green now. The unique thing about red found green is it kind of addresses a lot of the major challenges, which was inability to get access to data sets, inability to have the ability to design a very large model or have the computational power to do that. The major limitation which is still there is whenever you are adopting a model which has been developed outside or with populations who are not the target demographic, you will always require local validation data. Say, for example, if you are bringing a data into the African population and there is zero African training data set, there is always likelihood that the performance model will not be that good when you bring it into a new population. But the good part is, as the newer models are showing, all you need is about 300 to 400 images to retune the data sets. So it's a technical terminology. Basically, it means you introduce these new images to the algorithm, and then the algorithm can again get the same performance that it was getting previously. So always the critical part is when you are adopting it into the local population, there is a requirement of say 1,000 patients at least. Out of that, 300 can be kept for the tuning, and the 700 can be used for the local validation. If it's a very large model that is being adopted, most of the times the performance will be good and you can start to use it in your own clinics. Always, the critical part is sometimes these devices are also regulated. So you have to make sure you are not using something which falls in a class where it should not be used. Again, there are different classes of medical devices. So if it is class one, class two, which means that you are not doing something which will threaten the life of the patient immediately. Up to that point, it is quite easy to get the regulatory approvals. The moment you go into something which can predict like life or death in a cross-sectional way, say for example, if it's a model that is predicting risk of blindness today, that one will require more regulatory challenge, more validation, more strong regulatory documentation than say something like predicting fever, which is something quite simple to predict. So that is some of the main challenges that are still there. The lack of local validation data in certain countries, and another challenge is lack of people who are technically sound, doctors who are technically sound. So there are a lot of engineers who are doing very good work, but still a lot of doctors, they need more training and education in this field. So I would keep these two as the main challenges.
Well, Dr. Sahil, it was a very interesting talk, and you gave something new, educational to our audience. I hope it will be very beneficial, and it is something new, which is being supported by artificial intelligence, which is revolutionizing, in fact, everything. So I want to thank you on the behalf of my audience, and you have given us time to educate them, and we are looking forward to more sessions in future also. Thank you, Dr. Sahil.